Okay, class, we just finished talking about pulse oximetry, and now we are going to continue with part 2 of chapter 39. So some tests that we can use to help assess respiratory function. One is chest x-rays. Now, chest x-rays can tell us a lot of things. For one thing, it can tell us if you're getting air into the lungs. They'll look nice and dark like this. When you see white, filtery type things, sometimes you have what we call infiltrates or fluid potentially in the lungs. They can also tell the shape of the heart, if the heart looks like it's overly enlarged, if everything looks like in its proper alignment. So chest x-rays are a very helpful tool when it comes to assessing respiratory function. Another potential test that they can do is arterial blood gases, ABG'S. Now, ABG'S, depending on where you work, some places the respiratory therapist does ABG'S, some places the laboratory does them. So it really just depends. The first hospital I worked at, I know lab always drew the ABG'S. And when I worked at the next hospital I worked at, it was always respiratory who came and got them. But they actually put a needle right into the artery. So normally when you have blood drawn, your blood is drawn through a vein. But with arterial blood gases, they put it into the radial artery and draw blood, fresh arterial blood. And so it can tell us the pH of the blood. It can tell us, the oxygen level, the CO2 level, bicarb levels. There's a lot of things that this can tell you. And it can be a really important test for people that are having airway problems or respiratory issues. Another test that they can do is called a bronchoscopy. Now, a bronchoscopy, the physician will put a lighted instrument. Now, the person has to be sedated. They have to do conscious sedation. There's no way somebody could tolerate this if they were wide awake for it. But they put this lighted tube down through the mouth. It goes through the trachea, and they can put it into the bronchial tubes, and they can actually just feed it in as far down to the bronchial tubes as they can. There's a light and a camera on the bottom of it, and this camera is going to transmit whatever they're seeing down there. It's going to transmit it up here onto the screen so the physician can see if there's tumors, if there's any abnormal tissue. And there's actually little pinchers that they can go in. They can actually do a little biopsy if there's something abnormal in there and pull it out so they can run lab tests on it. Another type of test that they do is a lung scan. And this one, the patient's given a radioactive isotope, and they inhale it, and then the lungs are scanned to see what areas are not getting enough air or what areas are not aerating properly. So that's another test that can be done to test lung function. There's also spirometry, which measures how fast and how much air you breathe in and breathe out. Now, one thing I want to make sure that you understand is when we talked about taking care of that patient after surgery, and we talked about the incentive spirometer, incentive spirometers measure the amount of air that you inhale. Some spirometry tests that they can hook you up to can measure the amount you inhale or exhale. But incentive spirometers that we do at the bedside with our patients, and usually what you would do as a CNA at the bedside, it's going to be measuring the amount inhaled. A thoracentesis is not something I've ever seen done in the nursing home, but it is something that is frequently done in a hospital setting. If the person has fluid in their lungs, so you have your lungs, and then there's a space, okay, in between it's called the pleural, in between the lung tissue and the ribs, okay, and the outer, tissue of the body. So this pleural space, if it fills up with fluid or it fills up with some kind of infectious, pussy type of drainage or infected fluid that's in there, what they'll do is they'll put a needle in directly through the veins, and they can just the person's awake for this. They just lean over their table. The doctor will give them something to numb the skin up right there, and then just stick a needle in right through the ribs into this pleural space and draw out this fluid so they can run tests on it to see if there's anything, what's going on, if there's any kind of infection or anything going on in that pleural space. So again, I've not seen this one done in a nursing home, but I have seen it done a lot in a hospital. Sputum specimens, we talked about when we did specimens. With a sputum specimen, they cough up their secretions, and remember, it's not saliva, it's sputum, it's that phlegm from down in the lungs. And we said the best time to collect this is usually first thing in the morning because they've been sedentary all night, and now when they're moving around and stuff, it loosens up all those secretions. So when they cough up this stuff, that's when you want to get it. It can be, you can actually get a sputum specimen any time of the day, but we find that if you do it in the morning, that's usually when you have the most stuff that's rattling around in the chest. Another thing that we'll talk about next is promoting oxygenation. So as a CNA, probably the three most important things that we are going to do as a certified nursing assistant is positioning our patients, deep breathing and coughing, and the use of that incentive spirometer that we were talking about. Now, we mentioned these when we were talking about the surgical patient, but one of the positioning ways you can put a patient in is if a person's having difficulty breathing, you can put them in a Fowler's or a high Fowler's position, or there's also a position called an orthopenic position. And so this is when they can only breathe comfortably when they're sitting up. And what a lot of patients will do when they're really struggling to breathe is we'll put their bedside table across them, put a pillow across them, and they'll lean over across this pillow. And sometimes they can just take in a nice deep breath that way. So we'll usually start with just a Fowler's or a high Fowler's position, but if that doesn't work, sometimes this is another position that will work for them. The thing we have to remember with positioning is we need to reposition our patients frequently. So if they do have secretions down in the lungs, if they do have that sputum, they have that phlegm, all that stuff in the lungs, we don't want it to sit and pull in the lungs. We want them moving so it gets moving around, and that way it's easier for them to cough it out. So it is important to keep moving your patients when they're with respiratory patients. Another thing we do with our patients is we do deep breathing and coughing. So with deep breathing, just taking in nice deep breaths, and generally we take in nice deep breaths through the nose, and you hold it, and then you have them breathe out through pursed lips slowly. Okay, and then you have them breathe in deeply through their nose, have them hold it, and then you have them breathe out through their pursed lips. And you do that 3 or 4 times, and then the next time you have them deep breathe, you have them cough as forcefully as they can. And that will make the cough more effective. It will help get any secretions that are in those lower lobes, help them get it out. And then you have them take in a nice deep breath again. What deep breathing and coughing does is it helps prevent pneumonias. It removes mucus and it prevents pneumonias. It also helps prevent atelectasis. So we talked about atelectasis when we were talking about that surgical patient. Atelectasis is collapse of a portion of the lung, where the alveoli just collapses down. By doing deep breathing and coughing, where you're getting air nice and deeply down into the lungs, you keep those air sacs, those alveoli, from collapsing. And so then there's less chance of pneumonias. So that is another really important thing we do. So positioning, deep breathing, and coughing. And then the other thing, this picture here is showing you that if the person has an incision, so let's say a post-open heart surgery patient, or if they've had abdominal surgery, you can take a pillow and have them hold it right over that incision. So when they're taking their deep breaths and coughing, it's not quite as painful on the surgical site. When you are dealing with deep breathing and coughing for little children, turning it into games, having them blow bubbles, having them blow on a pinwheel, sometimes that's helpful to get them to take those nice deep breaths down into their lungs. The incentive spirometer we have talked about before. Incentive means encourage. The incentive spirometers measure the amount of air inhaled, not exhaled. And what you do is you're going to see these little happy faces. There's a happy face here in the middle, and there's a sad face and a sad face. A person can breathe in, they could inhale their air really, really quickly and get it to come all the way up to the top. But that's not going to be as an effective of a breath as if they breathe it in slowly, where they're keeping this yellow dial. It'll come up to this happy face. And if they keep the breath slow and controlled, it'll stay in this range right here. They may only be able to get it up half as far, but it's a much more effective breath. And this incentive spirometer is wonderful in preventing that atelectasis, that collapse of the alveoli, and preventing pneumonias. So not just patients right after surgery, patients that are bedridden, patients that have respiratory issues, patients that are having a hard time coughing and getting secretions out. These are good things that we can encourage with them. Now, oxygen therapy we've talked about. We said oxygen is a drug and the doctor must order the type and amount to use. CNAs do not give oxygen, but you do assist in helping provide safe care. So you can help gather up the supplies, get things hooked up, but the actual dial of the oxygen flow, the nurse is required to do that. So there are different types of oxygen systems. This is the type of unit we use in the hospital. This is a wall-mounted oxygen. It just plugs in and there's oxygen that flows in behind the wall. And then this right here, the nurse can dial in the oxygen flow. This is generally what we see in the nursing homes. The button right here turns it on. This will dial in the oxygen flow. Again, the RN or LVN is required to do that. And this is where the humidifier goes. And the humidifier is where you can have some sterile saline or some distilled water can be in it. And they run the oxygen through it, so it doesn't dry the nose and the back of the throat out as much. So if you have a patient who's on oxygen continuously and they're complaining of their throat being dried out, we just need to ask the nurse if we can add a humidifier. We are actually allowed to change out the humidifiers. We're just not allowed to dial in the actual oxygen flow. This is a portable tank for someone who's going to activities. Okay, so if they're going to go to activities, they would get hooked over to a portable tank. And this is something that, again, we can get everything hooked over to the portable tank, but then we'd have to swing them by the RN to actually dial in that oxygen flow. And then patients that are really active, patients that are on home oxygen and they like to go to the store, they like to go out and play with their grandkids, they have these little portable units. They don't last as long, obviously, but they allow the person more mobility. So with our oxygen devices, nasal cannula is the most popular one we are going to see in the nursing home. The prongs go into the nose and then it goes behind the ears. And we've talked about with nasal tubes, we always want to make sure that, on our shift, we take the oxygen tubing off. When we wash their face, we check behind the ears, we check on those cheekbones, we make sure that there's no pressure points happening because our tubes, we said, can cause pressure points. Nasal cannula for every liter of oxygen that you're giving the person. So if you're giving them 2 liters of oxygen, each liter is adding another 3% concentration of oxygen. So if you take that 21% concentration of room air and I'm giving them 2 liters of oxygen, I am giving them another 6%. They would be getting 27% concentration of oxygen. So that's kind of how it's calculated out. Babies a lot of times have oxygen hoods or oxygen tents. This is what the humidifier bottles look like. Simple masks, you can usually give 40 to 60% oxygen, and a non-rebreather mask, you can give 95 to 100% oxygenation through a non-rebreather mask. The person has to have a good respiratory drive. They actually have to have a good respiratory rate. They have to have a good, able to breathe air into their lungs, and this will give them will increase their oxygen rate. This is called a Venturi mask, and this one, it's similar to this type of mask, but there's a little device on it where you can dial in a more specific amount of oxygen. Some basic oxygen safety rules: no smoking, remove any substances that easily ignite, keep oxygen sources away from our heat, turn off electrical items before unplugging them, use only electrical items that have 3 prongs to them, and of course we recommend that you don't use clothing that causes static electricity. You are not allowed to adjust the flow rate. Do not remove the oxygen unless it's okayed by the nurse. Now, if the patient is on oxygen PRN, that means oxygen as needed. The patient can take it on and off as they feel like they want it. But if they're on oxygen continuously, we don't take it off without checking with the nurse. Let the nurse know if something seems wrong. If that patient seems any signs of hypoxia, fast breathing, fast heart rate, cyanosis, confusion, we let the nurse know. Make sure there's no kinks in your tubing. Report any abnormal signs of difficulty breathing or signs of hypoxia. And if there is oxygen, we want to remove the oxygen source with our patient when we're getting them out of the room, or turn off the oxygen if we have to. And lastly, when you're caring for a patient with oxygen, again, check for signs of irritation, keep their face clean and dry, frequent oral care, and make sure your humidifier is working. You're going to know it's working because it's going to be bubbling. I hope you enjoyed your lecture on oxygen, and we'll meet again.